Good afternoon. I'm Lori Riemann-Schneider. I'm the healthcare administrator at the Forum at Lincoln Heights. I've been a healthcare administrator for 20 years, aging myself. So we're kind of going to go back to the basics a little bit with my presentation and just use some pretty basic means. We'll visit a little bit about some of the more clinical aspects about long-term care, and then we'll watch a movie and we'll kind of switch hats. I'm a social worker, parish worker / licensed facility administrator, so we're going to kind of switch hats both ways. As I'm talking, one of the things as you're talking about hormone replacement therapy and those kinds of things, obviously the men in the group don't maybe benefit as much from that. Typically, when I visit with folks, what I talk about, unless unfortunately your parents are gone, this is something you will use both personally and professionally. So kind of put both hats on as we talk and we listen. And please stop me anyway through if I'm not making myself clear. Some of the Medicare information gets a little in-depth, so just holler at me and I'll stop. If you go ahead to the overhead. When we do our counseling with families and we talk about long-term care and long-term care lingo, we talk about we're not in Kansas anymore, and that's my kind of little joke. I said I didn't know how timely it was in face of the stuff that went on in Dallas this week, but typically when you step into long-term care and you step into skilled nursing facilities, you step into a whole new way to speak, whole new lingo, and it's very difficult even for our physicians that we work with. A lot of times the physicians are the ones who I get in my office who say, what's going on with mom? Break it down for me. So we're going to talk a little bit first about learning the language. Long-term care is what they used to call a nursing home. We've tried to make it a little flashier, to make it a little nicer, but long-term care is a nursing home. These days there's lots of different kinds of nursing facilities. They're licensed in many different ways. We'll go into that a little bit later. Am I okay? Okay. Great, thank you. Thanks. Skilled nursing facilities. Skilled nursing facilities are facilities that are licensed as a nursing facility to handle folks that have needs that must be met by a licensed nurse. Medicare recipients must receive care in a skilled nursing facility. They used to be intermediate care facilities and skilled care facilities. It's all under one umbrella now, and that umbrella is called a nursing facility. Personal care. Probably down the block from your house, you have a new personal care building. They're jumping up all over the place, and folks say, what is personal care? The personal care regulations are very, very broad. So there are a lot of folks that interpret these regulations a lot of different ways. Basically, according to the state regulations, a personal care type A building is one where folks can self-evacuate. Means they can get up, they can go on their own, maybe with a little queuing, but they have to be able to seek an exit. Personal care type B is a type of facility where they can be assisted through wheelchairs, through staff taking them by the hand, those kinds of modes of evacuation to get out of the facility or the community. There are many different models. Different corporations or owners have many, many different models for these. Some are nurse-based, some are social-based. As you're looking at those, should you need them personally, really go in and take a look at things like who's administering the medications, who's keeping an eye on folks. And there's just, the new legislation has allowed us to age in place, our folks to age in place, which is a wonderful thing. If mom moves in, she is 85, she's had a small stroke, she has another small stroke, and she just doesn't do quite as well. The beauty is she gets to remain where she is. The downside to that is that sometimes aging in place requires you just require a little bit more care. Special care needs, the new Alzheimer's units, we've become pretty specialized in this as well. And there are both special care units that just are personal care, meaning they're folks that just typically those are the folks who need a secure environment, folks that are exit seeking, that need to just be kept and contained safely. Then there are skilled nursing units that actually provide licensed nursing care for folks that are just higher needs. Any questions about any of those types that we've talked about? Okay. Staffing makeup, there will always, and this is in a skilled nursing facility, there will always be a licensed healthcare administrator, DON is a director of nursing, a social worker. There will be different levels of RNs and LVNs. Medicare only requires that there is an RN on 8 hours a day during the working hours, so typically the rest of the shifts are filled with LVNs and medication aides. Know when you go into a facility what you're dealing with, what they have on staff. Certified nursing assistants are folks that are certified by the state of Texas. The new laws, it's been 10 years now. Laws 10 years ago required that all of our nursing assistants had criminal history checks and were certified by the state of Texas. So in a nursing facility, every nursing assistant must go through that. Those are the folks who provide the hands-on care. Hospitals, a lot of times, it's the LVNs and the RNs that are doing primary care. Here in a skilled nursing facility, it's actually your nursing assistants. Within those skilled nursing facilities, or even within an assisted living setting, you should have rehabilitation services available, either on-site. Many of our assisted livings have available through a contract. You probably all know what PTOT and speech are. For those who don't, the speech is the one that I want to elaborate a little bit on, is that the speech therapy not only deals with the actual function of swallowing. I think we spend a lot of time each week visiting with physicians about speech therapy. Also deals with your dementias, it does deal with your actual speech and your swallowing, but the dementia component and the cognitive component of speech therapy is a very important part of what a speech therapist can do. They can help with transitions, such as using things like memory books and those kind of helping techniques. When we're working with folks at the age level I work with folks at, I believe it's very important that we do functional PT and OT and speech, but PT and OT, meaning the folks that are receiving these services truly need to, if at all possible, receive those services and the training in the environment that they're going to use the information. Meaning if they're going to use it on and off the bed, that's where we need to train them. There are some things we can use on and off a mat, but I think a lot of times the carryover is so much greater if we train people in the environment that they're going to use the information. Payer sources is our next subject, obviously private pay. Ballpark, anywhere from $80 a day for a semi-private room to $120 a day semi-private room. Anywhere from $125 a day for a private room to $250 a day for a private room. It's kind of all over the board for private, but those are typically the industry rates right now. Right now the industry's seeing about a 4 to 5% increase in rates each year for private pay. Medicare Part A. Medicare Part A, as you all know, functions in the hospital setting. We're just going to talk how it functions in a skilled nursing facility right now. I'm not even going to take that other part on. Medicare Part A in a skilled nursing facility requires a 3-day hospitalization in an acute care setting. That means 3 midnights in an acute care setting. And they must be inpatient in an acute care setting. Medicare Part A, then upon having a rehabilitative or a teaching or something that requires a skilled licensed need. Obviously therapies require the oversight of a physical therapist. Diabetes is another one. Teaching new colostomies, new diabetics, and those kinds of things. Rehabs for your folks that have had strokes. Medicare pays day 1 through day 20 at 100% if there is documentable progress in the patients or in the residents' progress throughout the course. So day 1 through day 20 can be at 100%. Day 20 through day 100. Medicare pays everything, room and board, all the therapies, any urological supplies, ostomy supplies, provides all of that. Pharmacy provides all of that after the patient pays $96 a day. Really trying to kind of break it down. If someone has a secondary insurance, that is typically the time that secondary insurance will pick up. Typically, it's some of the old timers are, if Medicare pays, that secondary insurance pays, that's the time that it'll pay. No one is guaranteed 100 days. So a lot of times folks will come to us and say, but I know I have my 100-day skilled nursing benefit. No one is guaranteed that. As the Balanced Budget Act came around, those were some of the cuts we saw, is how long people were under Part A. Medicare Part B in a skilled nursing facility or in long-term care or in assisted living, Medicare Type B pays for their outpatient rehab services, meaning pays for things like therapies, urological, enteral feedings, those kinds of things. Not the room and board, it just pays for the delivery of services. It pays at 80%. Again, secondary insurance typically covers up that additional 20. So that's when they can normally use both of those types of, they can use their insurance. Managed care, your Secure Horizons and those kinds of folks, they do have contracts with some of the area nursing centers. Again, since it's managed care, you all are pretty much aware of how that works. Medicaid. Medicaid is a primary payer source. Medicaid, there are two ways to qualify. You must qualify medically through an assessment process. The resident must qualify through a financial process as well. Monthly, a patient can have no more than approximately $1,450 a month in income. They cannot have assets in excess of $2,000, excluding a house, a vehicle whose worth is not more than $4,500, a life insurance policy if it has no cash value, no surrender value, and a prepaid burial plot up to about $5,000. What happens is there are only certain facilities, communities that are participate in the Medicaid program. There are different things such as Miller's Trusts, which basically protects some of the assets that it protects a spouse in the community. I don't really want to go into that a whole lot because that's a whole legal snafu that I just don't even want to come close to talking to you about. There are many folks, and I can get you names if you need those, that do that in the community, and they can help people secure those assets. The important thing to remember is if someone is within 6 months of spending down to a Medicaid level, they really, really need to get into a facility that takes Medicaid funding. There's also a caveat, and they're looking at this very closely now. It used to be the 2 years. Most everyone knows that if you deed over all your money 2 years prior to the need, you can then be under Medicaid. If your monthly income is less than the $1,450, they really look at that closely. When Medicaid takes the patient's money, they take the money and leave a $30 stipend each month, and those are for the incidentals that the resident should need. So that's not a lot. If you have elderly parents or have anyone you know that's looking at some Medicaid funding, it might be worth your time to take some time to talk to some of these attorneys or financial folks about really where you can utilize those funds the best way. Any questions about any of that? For the spouses, there's a Spousal Impoverishment Act that came a couple of years ago, and basically what it says is you can have that the spouse gets half of the resources. It splits at $150,000, so they spend down to $150,000 and then it splits, so 75 and 75. That's important because you used to think that you had to have no funds, both spouses had to have no funds. They now realize that doesn't make good sense. We talked about the insurance. There are insurance policies out there that do cover long-term care. If you have someone you know, or if you're looking at personally, call one of the skilled nursing facilities and ask that admissions person to just take a look at that policy. There's different ways things are worded. Some of them work in assisted living, some of them don't work if you have Alzheimer's. So if you're looking at that, there's some typical buzzwords that folks can take a look at. All right, services in a skilled nursing facility. Rehab we talked about should be real easily obtained. I know that Dr. Promomo is going to visit with you all a little bit later on hospice, and she'll go into the wonderful, wonderful things about hospice. How hospice works in a long-term care facility is we have a partnership with a hospice. The resident stays in the facility with us. Obviously, they have the diagnosis of 6 months or less to live. Dr. Promomo, again, will go through some of that with you. We partnership with the hospice agency to provide aggressive palliative care for that resident. The things that the hospice does for us is it supports the family, it supports the resident, and it supports our staff. Many of these folks have lived with us for 10 years, 12 years. So as they're passing, it becomes very difficult for the staff and for the families. It's just a real big family unit in a lot of the long-term care centers. Hospice comes in and makes sure that we keep them really pain-free. Works with counseling the family through the end of life kind of issues, and I think you if you have not had, I think you're going to have a talk on some of those end of life issues as well. Feedings, no feedings, those are the easy ones. CPR, no CPR. The more difficult ones become antibiotics, no antibiotics, hospitalization, no hospitalization. Hospice helps those families walk through those different kinds of things. Every long-term care facility should have a psychiatrist or a psychologist. We'll talk about that a little bit later, but those are folks who can come in. I would say probably 50% of our patient load right now has got some need for antidepressant therapy, some behavioral issues or things like that. We don't chemically or physically restrain. Most facilities anymore are restraint-proper facilities, so these folks help us manage those a little bit better. Dietitian visits, pharmacist visit, these are folks that come in once a month and look at all the patients, no matter who you are, no matter what the payer source is. Primary physicians, not every primary physician will come. Most of you know that now. They just get spread so thin, but each facility does have its list of physicians that pretty much will work in that facility. Every facility also will have a restorative aid program. This is at no charge to you. It will be very short, but it will be to keep the level of functioning up so that the resident, there's many, many studies that show that the minute they go to bed, I think Dr. Mouton spoke about this, the minute they go to bed, their ability and their mortality just increases dramatically. This is to keep those folks up and moving and going as long as we can. The admissions into a skilled nursing facility, some of you work with folks who are doing that or will have to do that. Classically, 3 or 4 times a week when I counsel families and they're coming in to look at the community, we talk about, oh, mom's never going to be ready. She's got at least another 2 weeks. Well, with the DRGs, that's not the way it is. Diagnosis-related groupings, you go in with pneumonia, you have X amount of days in the hospital. They need to get you out and move you on to the next level of care. So typically, these folks are out a lot sooner. If I can say anything to the folks around, it's that don't try and crisis plan. If you know mom and dad are aging, really look at what's available in your community. Another thing is, when you have aging parents or you have parents or someone you love in a skilled nursing facility, truthfully, the best thing to do is get them as close to you as possible. Talk about that partnership a little bit later as well. Not every nursing home is for everyone. We don't do trachs, and we don't do we do trachs, but not a lot of them, or vents in my skilled nursing facility. I have X amount of nurses, I have X amount of folks that I have for care. That's not what we do as well as other facilities. We tend to do good old-fashioned rehab. We do good old-fashioned love and care. Every community is very, very different. Know what you're looking for. When you're looking at the community, they're very different. Every community is not for everyone. Advanced directives, you'll go through that. Again, very important both for you, my commercial time, both for you and for whomever you're with, talking to, counseling, or working through. Again, the advanced directives are not just CPR, no CPR. The advanced directives are not just tube feeding, no tube feeding anymore. Those are kind of basics. That's kind of easy to talk to folks about. What happens when mom can't swallow and she has her advanced directives, no tube feeding? You know, what about when you don't feed her? What about if you aren't going to send her to the hospital? At what time do you kind of let go and let that person pass beyond? Those are the things that when you're counseling with families and working with families or residents, those are the things that become very troublesome for folks, and working them through that. Every nursing facility should have a plan of care. That should be an integral part of what you are doing. That should be part of the partnership. Families should be invited to that. That's something you can expect routinely. Any questions about what we've gone through? Great. Going to change hats. We're going to watch the movie Peach. It is very, very old. If you've seen it, bear with me. But it's for my business and for what I do, it's really, really effective. Probably have seen that 10 times. And just a couple of points off of that video that I'd like to make. As I told you to, my handout said open your hearts and judge not. A couple of things. First of all, that family is going through one of the most difficult things, obviously the placement, the whole thing, but what we call anticipatory grieving. As we walk down the path of losing those we love, once we've lost them, there's almost a recipe for how we act, if you will. You know, the stages, Kubler-Ross's stages, those kinds of things. But many times families go through 8 years of that anticipatory grieving of losing a loved one, and that's so difficult. We as professionals walk in many times into these folks' lives, and we only get that snapshot of an 80-year-old. And after doing it 20 years, I find myself doing that as well. You look at the 20-year-old, and as much as you don't want to, you forget the Nana. You forget the times that they did rowdy things and took them out for ice cream before dinner. And I challenge you, as you're working with our folks, to remember that we're only getting that little snapshot, and try to honor that part that came before. The other thing, to just really open your hearts to the fact of therapeutic touch. I work with many folks with dementia and have through the years. I teach classes to first graders on aging and those kinds of things. And what I tell them is, as like Nana and like Paige did on the video, residents with dementia or cognitive loss really on one level may not know what you're saying, but trust when I tell you they know what's in your heart. It's kind of like little kids do a lot of times. They know what's in your heart, and you can connect. The power of touch and the power of working with these folks is phenomenal. And a lot of times as practitioners, we need to teach our folks, just as that family, they were doing the best they could. They loved their Nana. They just didn't know how to show her. This was not the Nana of past, so how did they deal with it? They were really trying. Our job is to take their hands in that partnership and walk them down that path, that very, very difficult path, and help them embrace the aging, if you will. My last point is take care of your stuff now. With kids, grandkids, parents, whatever. Don't age. Aging is difficult enough, let alone aging with all the siblings that you may not get along with, the friends you don't get along with. Because if you take care of it now, your aging will be much more gracious and much better. And those around you, remember that your children will treat you as you have taught them by the way you treat the elders in your life. Any questions? Told you I was going to kind of change hats to the spiritual or the social work part of that. Thank you all for being here. Thank you.